First of all, the webinar is being recorded and it may be used for future promotional work. So if you attend today, we'll assume you confirm your assent to that. For any technical issues, please use the chat function or email cfsdgreentheatres@ggnh, Golden Jubilee National Hospital.scot.nhs.uk, and the team can assist. And please also ensure your camera and microphone are switched off. Thank you. So I'm going to first of all introduce the panel. You can see the agenda there. We have three main talks from really experienced and expert people. The first, we're going to be starting with Mike Ralph, who is the head of energy at National Services Scotland. He was also chief engineer in England, NHS England, for many years, so has vast experience in this area. Followed by Paul Weaving. Paul Weaving is a nurse consultant at High Scotland, doing significant work with the National Green Theatres programme as well. And then we've got a tag team of three representatives from GGC, NHS GGC. We've got Lorna Young, the Sustainability Manager there, Martin Johnson, Head of Sustainability, and Malcolm Watson, the Consultant Anaesthetist. And they're going to be talking about the local success they have implemented in Glasgow. So, first of all then, I'd like to welcome Mike Ralph, as I said, Head of Energy at National Services Scotland. He's going to talk about the impact of the engineering insights. Thank you, Mike.
Thank you, Ken. Oh, what wonderful, Stephen. You're curating it brilliantly for us today. I mean, there's been a lot of sort of discussions, and I mean, and some of you on the call I've spoken to, you know, individually with specific problems on your sites and health boards. I mean, these are the extracts from the HTM. So we're not starting off with saying that it is okay to do this. We're not sort of saying something now which hasn't been considered and is sort of a derogation away from normal operation and running. I mean, and it's quite clear there, you know, what it says and what the overall guidance of it is. I mean, to put it in context, before a long time ago now, I was director of station facilities at Great Ormond Street Hospital in London, and they've always been very forward thinking because they're dealing with children and the first do no harm piece. You know, if we're harming the environment, we're healing children, then to put them into a world which is being damaged. So they were very keen on sustainability, and this is like 20 odd years ago. We looked at the energy usage from our theatres, you know, then. And with a very good understanding, cooperative, integrated infection control team, we turned the theatres off at night anyway. I mean, the one thing was that we put a physical barrier on the door, which through time we found we didn't need. And it you know, it took an awful lot off my electricity bill was the main thing. But of course, obviously, there's all the carbon that then sort of didn't go into the world. At that time, that was. It was changing from 2025 to the HHMO3. That was quite a change, and you know, and there was a lot of sort of thoughts and consternation. But the good piece with GOS, well, I suppose it's a good piece, is that there's 100% surveillance on all patients because of you know, it has less restrictions than a normal sort of DGH or a teaching hospital would have, and you know, the patients are there because there's something, you know, novel or seriously wrong with them. So the surveillance is there. It had absolutely no difference on SSIs or anything sort of, you know, related to that. So it was key, and that's been their customer practice and is now integrated into the operation of their units to one degree or t'other. Bear in mind that unfortunately, it's pretty much a 24-hour hospital these days, so there's all something going on. But I mean, so you know, it's to set in the bar. This isn't something new. It's been around for a long time, and there's a lot of things you can do. Now, there's some sort of companies, these escrows, which are, you know, that they do the work for you and then take a small percentage of your saving, have been very keen to explore this in England, not so much in Scotland. But they've worked with a lot of sort of trusts in England to look at this, and the estimation from it depends on the size of your theatres, your motor size, etc., etc. But on average, for a 9-hour shut off in your silent hours is approximately 7k a year in money, and sort of a lot of carbon tons. So there's an incentive to do this, and that's not at any sort of derogation to patient safety, or the infection control risks for your health board. So if we go on to the second slide, please. This is like the hierarchy of what you can do, and the effects that it has, and how you can sort of work on down through it. So you've got obviously the do nothing scenario. You stay the same, and you work with whatever you've got. I mean, this tends to look at carbon and energy costs, but don't forget, if you're using plant less, there's less run hours, there's less wear on it, so you're changing your filters less, you're changing your belts less, etc., etc. So there's incremental changes on this, but this is the pure measurables, and a lot of the time with fixed periodicity maintenance, you're changing them anyway, so it's almost negligible. But so the first one that you can do is to set back your supply and extract. Easier on sort of modern motor control systems, but unless you've got 2-speed motors installed, which tends to have been the case in most healthcare applications, that's already the position you probably find yourself in. Now you can still save a fair bit of electricity and carbon with that, but obviously it's still more, as was said in section 3.9 of part B. It's not as much as if you sort of turn it off. So the next option, which still maintains a level of protection if there are IPC concerns, and obviously Paul's sort of going to cover that, and where your actual biohazards come from later, is to set back your supply and put your extract off, and that way you've still got that positive pressure within the theatre suite, and it's still sort of giving it that balloon of protection if you feel it's needed. But then you've actually got the extract motor isn't running and isn't doing, so you're saving all that energy. The fourth option, and the one which is to be encouraged, is the fact that you turn off both the supply and the extract within the silent hours when you're not using it, and that's 100% saving on what you're doing, because you're not using it, and you get the extra efficiency on the equipment, as I said earlier. Key concerns about sort of temperatures and humidity, etc. You've got to identify if that is a real risk or if it's a perceived risk. I mean, if you've got a closed room with no equipment turned on there, no source of moisture, what's going to happen? It's a closed box effectively. So if anyone then goes in there, or you have to take something in there, well, then you need to activate the ventilation system so that you're cleaning and purging that area. And likewise, when it goes on in the morning, these are high air exchange rate areas, and they're only sort of flow rate and energy intensive, so it doesn't take very long to have completely sort of swept that room a couple of times. So normally in the period that you would have to, or the notification that you would get to set up to need that theatre, with ventilation running for that period of time, it will get it to your operation indoor air quality levels. I seem to have shot vastly ahead of time, so I think it's more probably for sort of questions at the end rather than just sort of stating what's there and what we've got. So I'm a bit ahead of time, Ken, but probably best to hand over to Paul.
No, that's good. I'll just mention, I should have said at the beginning, we have had pre-submitted questions from a good number of people, so thank you for that. We are happy to take questions in the chat function, and Stephen and Ian will be passing those over to me at the end. But it is a webinar busting the myth, so we are hopeful that we'll get a discussion at the end of things, because an awful lot of people have had an idea of how to progress with this action, but have a number of questions about how to practically put it into place. So there'll be hopefully a discussion more at the end. So now to welcome Paul Weaving. As I said, he's nurse consultant in infection control, and we'll be dealing with the key infection control considerations and surveillance. Thank you, Paul.
Great. Thanks very much, Kenneth. Thank you for inviting me to speak this afternoon. I've a horrible feeling I'm going to repeat some of what Mike's already said. I always think it's worthwhile with this sort of thing to go back to basics and think about what are our concerns, and what are we actually trying to do, and what are the engineering controls actually trying to control. Can we move on to the next slide, please, Stephen? Okay, you'll need to click on a bit. Our main concern, we're talking about patients that are undergoing surgery, and surgical site infections are a cause of morbidity and mortality in patients still. They are multifactorial. There are lots and lots of things that influence whether or not your patient who is undergoing surgery is going to get an infection following surgery. But one of those factors is air quality. And what we're looking to do with an HVAC system is maintain temperature and humidity, which are factors that influence likelihood of surgical site infection, and particularly reduce airborne particulates, things that are present in the atmosphere, either free-floating microorganisms or particles that have microorganisms attached to them that may contaminate either the operative field or your sterile field, and then the operation site secondary to that. Move on, please, Stephen. Thank you. And there are specific aspects of the airflow system that help limit airborne particulates. We've got a continuous supply of clean air into the operating theatre, and so we're diluting anything that's in there. We're reducing the amount of any contamination as a proportion of the whole volume of the theatre by, as I say, continuously introducing clean filtered air. We have a particular airflow format structure within the theatre, and that's designed to move potentially contaminated particles away from the operative site, so our airflows. The introducing clean air into the operating theatre allows that theatre to be at a higher pressure than the surrounding area, and so this prevents the entry of contaminated air, and so we have pressure differentials that also help reduce the risk of contamination. And as Mike said, we have an extract system going, so we're continually introducing clean air, and then we're extracting any contaminated air or potentially contaminated air. And remember that the majority of your contaminants that may impact on the patient are going to come from the people who are in the operating theatre. They're going to come mostly from your operative team. And so when your operative team isn't present, these are going to be much, much less of a concern. Move on, please. But it's a not unreasonable concern, and certainly one that I would have if I was an infection preventionist working in a board or a NHS trust, as I have been in the past. There's a concern that interfering with your ventilation system in any way, including frequent switch off, switch on, may disrupt the effective operation of that system, and so potentially increase the risk of surgical site infection. The first thing to say is that we want to reassure ourselves that that isn't going to be the case. As I'm sure Mike will reiterate, a properly functioning HVAC system shouldn't be impacted by being set back or being turned off, whether it's once or multiple times. But some boards have expressed concerns to us about older plant. So if you're concerned about your plant, the first thing to do is discuss with your estates and engineering colleagues about what tests you need to do to provide assurance of proper functioning. Now, we carry out tests on our HVAC systems when they're commissioned, and we do annual revalidation. So are we going to be looking at, if for example, there's a concern that something may not be coming back up to spec as quickly as you want it to, is there a scope there for actually doing your commissioning style tests immediately after switch on, for example, just to reassure yourself that your system is actually coming back up to functioning as it should be. And I'm sure Mike would have much more information than I will about what might be appropriate there. From an IPC point of view, the best assurance is through surveillance of surgical site infection, because this is going to give you early warning as to whether something is wrong or not. And if you've got a robust surgical site infection surveillance system in place, this provides you assurance that all the theatre systems, not just the HVAC system, but your working practices and everything else, are working as they should be to minimise any risk to patients. And it will give you an alert when things are going awry, if they do. Now, national surveillance systems are currently paused. This doesn't preclude local surveillance on the same lines. And all the, move on to the next slide, please. And all the national surveillance protocols and the resource packs are still available. I noticed Stephen said the slides will be available after the seminar, and so you can follow that link and you will see all the resources are there. Now, I appreciate that IPC teams are under pressure. IPC teams do not want to be implementing yet another surveillance system. So that's going to be part of the discussion about if you're saving sufficient resource by setting your theatre back, can some of that resource actually be rediverted into surgical site surveillance system to give you assurance that actually no harm is being done by introducing this cost and energy saving measure. And I'm going to leave it there. Stephen, I'll pass back over to you, Kenneth.
Thank you, Paul. And interesting, the last point you made there comes up again and again in many actions that we look at. It's that ability to recognise that savings in one particular financial silo could be actually utilised to help out another particular area. And that's a difficult thing to do within health boards sometimes, but it involves a lot of discussion. And if you are seeing benefit from doing something, it can pay for some other areas such as your surveillance enhanced protocol, as you mentioned. So thank you for that. So this is HVAC setback or switch off was something that was considered many years ago when first talking through the ideas for an ideal green theatre. We're very pleased that GGC, Martin Johnson and his team, were able to enact that in Glasgow over the past year or so. Took a lot of work. I know from speaking to the people involved, it was not the easiest thing to get going, but also was the difficulties of being first out. And we hope that their experience will help others have a much easier journey to implement this action. So I'm hoping that Malcolm, Lorna and Martin are here and ready to roll. I'm not sure which order they're going in, but we'll hear some description of how they put this into action. Thank you, guys.
Hi, Stephen, do you have the presentation for us?
Yes, it's Ian that's sharing the slides just now, so Ian will just move it along for you. Thanks, Lorna.
Thank you. Thank you. Hello, everyone. I'm Lorna Young. I've probably met quite a few of you before. I'm going to keep this quite high level until you've got more questions for us thereafter. Can you go on to the next slide, please? So I was asked to give you an overview of how we started, where we started, and how we got people on board, and then looking at what we've achieved to date and what our future plans are. So that's what the presentation is going to be touching on. Our starting point was we're a rather large and complex organisation. So the best way to start that was to look at our governance forums that we would need to collaborate with and look at who the key stakeholders are throughout clinical services. And it's with great thanks, I have to say, that without our clinical leads in each of the sector sites and each of the hospitals and the general managers, this would be impossible to do and move forward. So I have to say I'm extremely grateful. I've only been in post a year, and a lot of this work for building those relationships was taken on by Malcolm Watson, who is the clinical lead for NHS GGC, and he's on the call as well to answer questions moving forward. So within our area, we have quite significant number of governance groups that we need to report into. And to help us cover all bases, what we did was we looked at each sector and we did a sector delivery group, which would be responsible for implementing NGTP actions, and that would feed into the clinical sustainability group, which would oversee the programme on behalf of NHS GGC board. So by doing that, we were able to capture those clinicians we needed to and get them on board. Can you go into the next slide? And we did a lot of stakeholder engagement through that. I think it's very important to note that a lot of clinicians don't have sustainability within their work plans, and a lot of them are doing it, some of them in their own time, and we're very grateful for the input that they put there. So this included, we let surgeons, we've been engaging with surgeons, consultants, theatre staff, theatre management, IPC, very important to get on board, not just at that high level, but at your local level as well. Estates and facilities, energy, capital planning, because this all works together. You can't see sustainability in isolation. It's actually, that's what the jigsaw is about. It's every single part of it fits together. So that financial savings, we've got financial planning, we've got corporate planning to make sure that we've got it within our corporate plan, our delivery plan, so that it becomes embedded within the organisation. The health and social care partnership should form part of that process as well, because there's lots of savings to be had within their buildings. Although they look at green theatres as being only clinical, it could actually be in relation to their buildings and how they work their HVAC systems and treatment rooms, etc. The contractors and service providers, GPs, etc., and primary care services and dental services, all part of, that's just like a quick overview of all the stakeholders. On top of that, we have to make sure that we keep the senior leadership, both at a clinical level and executive level, on board, and how we move, what information they need to provide assurance to them that the programme's worth doing and that we can move forward with it and it's not going to cost us any money. Or if it is going to cost us money, then we can kind of show a business case for return on investment. Next slide, please. So we initiated, our first job was to initiate a pilot at the Queen Elizabeth University Hospital, and that was in 2 theatres, 19 and 20. Now, I did some analysis the other day, and I was absolutely stunned to find out that we actually saved nearly 60% reductions in kilowatts per hours used across those 2 theatres, from one period in 1 year to the next period in the next year. And I'm not sure if that's right, 1.2 tonnes, might be. Sorry, I'm just thinking here. So the barriers we face there, the lack of engagement, the culture change, we actually found it quite difficult to have management input at the local level to help drive it forward. We had some staff very keen to keep going the way they were going, the way it's always been, the attitudes and the behaviours. Change is difficult for everyone. So to try and get around that, we developed a standard operating procedure, which is still being added to as what we're learning as we're moving forward, is very beneficial. We got buy-in from the corporate management team, which was more than needed, so that we could drive that from the top down as well as the bottom up. And what we found out was that a lot of across the sectors were all working in different ways. So they were working in wee silos. So it's about trying to bring all that together under the clinical sustainability structure. Next one, please. So to date, we've got 8 theatres online at the Queen Elizabeth University Hospital, and Royal Alexandra, Inverclyde and Vale of Leven are set back to some level. And from there, we have, at the end of February, we saved I've just done a new calculation, so it's more than that, it's like £211,000 and 200 tonnes of CO2 for those theatres that are now included in that moving forward. It's difficult. This is based on the data that we've captured from the BMS system at Queen Elizabeth University Hospital. And basically, we're working with energy colleagues for those that don't have BMS systems and how we can calculate that moving forward in the future. So I'm meeting with them next week to understand how we can actually provide assurance around those figures. But these are the figures from Queen Elizabeth University Hospital and those 4 sites. Next slide, please. Our long-term aim is to implement our remaining theatres over 25-26. And we are now got the authorising engineer on board with us to help us undertake risk assessments and identify theatres that are high risk for the organisation. And the reason we're using the authorising engineer is to provide assurance to our governance committees that this isn't going to affect patient care along the road. We're actually not had any feedback on any surgical site infections from the pilot, and we don't have anything from those already brought online. Our plan is to, by October, hopefully next year, but this year, is to put the remaining sites online, which would give us 806 tonnes of carbon savings and £850,000 savings. So that's not something to be sniffed at. We're just in the process of planning that out for this year. I keep saying next year because my head's still in the old financial year. Next slide, please. Oh, that's us. Thank you. Do you have any questions? Malcolm Watson's here. He's our clinical lead, and Martin Johnson, Head of Sustainability, is here. And between us all, we've got some knowledge around this. So if you want to ask some questions, we'll be happy to answer them.
Great, thank you very much, Lorna. We are marching ahead here, which is great. It means we're not, we're getting straight to the point, not bothering too much fluff in our presentations. We do have a lot of pre-submitted questions and I see on the chat function that there's a lot of questions coming in. So hopefully we'll get a good discussion going here. I'll say at the end, before I forget, at the end there's a QR code that will be put up and invite you to give feedback on the webinar and the Q&A afterwards. So thanks for that. So I'll just launch straight in because there's going to be quite a lot of questions to get through. We'll come to Lorna, Malcolm and Martin first with the GGC. It's a specific question about the costs. So what are the costs for putting the changes in place, especially in older sites that you've been looking at, such as, for instance, Stobhill? Have you got an estimate of the return on investment period? Thanks.
So the Stobhill site, just to be clear, is an ACAD, a PFI site. So it's very, very new. There's no old sites at Stobhill we're looking at just now. We're targeting our newer sites that have the newer systems and controls. Any associated costs would be liaising with our PFI provider, in that case for our 2 main sites, which would be the New Victoria and Stobhill, or for our systems provider here at Queen Elizabeth, Schneider, to update the strategy ventilation strategy and the relevant control panels. To date, that's been a couple of £1,000 to initiate that work, which pays back relatively quickly. So there's not like there's a large budget required once we get past the easier sites, so to speak, that have less controls, less modern systems. That's where we start to veer into set back and how we can control that as best as possible, and where, as part of our asset ventilation strategy, which is happening in our part of our directorate just now, all this work should justify then investment into newer systems and newer assets to facilitate this level of control, broader than just the financial savings and the carbon savings, but also the resilience of service as well. So we're very much, there's like two strategies effectively working in tandem, depending on the age and the technology available to us, but the investment just now is very minimal.
That's great, Martin. Thanks. I'm just going to bring in another question that actually relates to the PFI sites. Obviously, you've been able to deal with that fairly easily then, from what you're saying with the Stobhill site in Victoria. Another question had come in saying that PFI sites it's been difficult, an inability to meter and therefore track and estimate energy usage and savings. So how did you get around the PFI relationship? How did you have to change your contract agreements, etc., in order to access that sort of stuff? It's obviously been a problem in other areas.
I think our energy lead has given me a response to that, and what they're saying is that I think it was in relation to Stobhill that they run the same system as the QE, so that shouldn't be a problem getting that information. The only thing is that we would need to pay to have the modified ventilation control strategy put in place through their engineers. He hasn't fed anything else back other than that, I'm afraid.
Okay, thank you. I'm going to bring in Mike here. There's a specific question, Mike, for you. There's a question saying that if your AHU is located externally, then there's a worry that switching it off might have issues with the weather, how the moisture and so forth gets into the internals of the AHU and the ductwork. What do the panel think is best strategy for externally located plants?
Well, I mean, I saw that question. It's about content. I mean, right. If your plant's not weather tight, your plant's not weather tight. Whether you're turning it on or off to make any difference, you need to do something about making it weather tight. In reality, if it's condensation, if the plant is switched off, the dampers are closed, your frost protection's on there, there's a very small quantity of air that's actually going to be in that volume, even if it's 100% humidity. I was just trying to look on my quick psychometric calculator. It's a very minimal amount of water, even if it was to wet out. And what's it going to wet out on? There's no cold surfaces. Your filters aren't cold, and you've got a drift eliminator. Because in the summertime, when you've got high humidity, you'll have tons of carryover. So I think it's a possibility, but if you sit and think about the practicalities of it, it's never going to arise.
Okay. They may come back to specific questions on that again in detail. Malcolm, you got a question?
The way we would deal with that in our site is basically with the authorised engineer. We would get an authorised engineer's assessment of any plant that we're going to switch off if it was a complex piece of plant, so that we've got a risk assessment for that. And that's probably the way we would deal with it in GGC. But yeah, just I know, and I don't. The answer is I don't know the answer, but there's someone who does know the answer and can give us a risk assessment, and then we would work on the basis of that risk assessment to either set back or switch off as appropriate to the age and the capacity of the plant.
But Malcolm, that's what I'm saying. If you've got the plant in the design, if you followed the SHTM, the design will be so that you're not getting cold bridging and the possibilities of condensation or wetting out. And so if there's something wrong with your plant, that might be a problem, but that's because there's some older plants may not necessarily have all the same amount of drift elimination, and they may have different construction. But external plants are you know, you need something just to do work on them anyway, and particularly as you know, you can get some hard, you know, you got some marine environments up in Scotland which would be, you know, particularly harsh. So you know that you would hope that the plant would meet the requirements of the environment that it's in.
Okay, thank you. So on a kind of similar topic, but directed towards Paul, somebody concerned about the ventilation ducting in terms of lack of movement of air when it's switched off, with possible buildup of moisture and the potential growth of mold and spores. And then when the system switches back on, that gets blown into the clinical area. Could you just give your input to that, Paul, please?
Yeah.
Sorry, jump in first, but again, that's where does the moisture come from? It can only be within there. As I said, you need to look at psychometric charts of what you're doing, because there isn't, if there's no airflow, it's just the air that's within that duct. And even at 100% humidity, if the duct's insulated, where the condensation doesn't come out. So you know, you're thinking of a cold domestic window in a house. A ducting system isn't like that.
So these are the mists we're busting. But over to you, Paul.
Yeah.
Thanks. Yeah, just to add to what Mike said, I mean, all the air coming into the duct is filtered. There shouldn't be any spores coming in there at all. You could possibly, with older ductwork, have a situation where your ductwork has a hole in, or that could be a point of entry when it doesn't have outflow. But if your ductwork's got holes in, it shouldn't be, it's not compliant. It shouldn't be being passed when you have your revalidation. So there shouldn't be any entry of spores in there, is one thing. As Mike says, there shouldn't be any damp in there. So there shouldn't be a damp environment for spores to grow in. In the unlikely event that anything was blown out, I remember that we've got 20 plus air changes an hour in our operating theatre. Anything that is blown out should be cleared well before you've actually got an open surgical wound in the operating theatre. And the only other thing that I could mention is that fungi take several days to grow. An overnight setback or an overnight switch off shouldn't give time for anything that has got into the ductwork, as unlikely as that should be, to actually grow in there. So it shouldn't happen. And I think the last point is just to refer to our colleagues from the sites where this has already been done, where we have no identified fungal infections subsequent to introducing this.
Thank you, Paul. One for the GGC team as well. There's a worry that there's a need to do time-consuming and costly risk assessments for each individual theatre, and that's usually prompted by the ventilation safety committees. The question is, are they necessary, or can we infer from one type of theatre to another?
I got feedback on that, and because of the checks on theatres within any NHS facility are done on a continuous basis already, and more or less compliant. My feedback is their safety committees are happy with the downtime of the switching off of theatres with regards to the assurance around that. They don't seem to think that there are problems, and that's why we've taken this risk-based approach in that we're doing the more simple, more modern theatres first before we look at some of our older estates such as GRI and the RAH, etc. The RAH are in setback in some theatres, but there are some issues out there that we need to kind of look at going forward. Did that answer your question?
I mean, I'm happy with that. I don't know who this question came from, but we're actually just.
I don't think there's a need to get an authorised engineer to risk assess. we've taken that initiative because of the sensitivities around the public inquiry for us, and we want to bolt embrace this moving forward so that we don't, we provide assurance to our senior clinical leadership team that we're doing this for the right reasons, and they're not doing it just to save money, and we want to make sure that patient care is unaffected.
Okay. So we've got an awful lot of questions in the chat that I'm just going to try and move through. Oh, sorry, Malcolm, you want to come in on that?
Just to reiterate Lorna's point, you've got to understand the environment in which we operate in terms of the political environment as well, and the sensitivities around infections at the Queen Elizabeth site. So we've had to bear that in mind when we've been writing these policies. So we very much have taken a belt and braces approach to this. But I would say that part of this, something that I've learned as part of moving forward this, you can't really just switch theatres off in isolation. It has to be part of a sort of whole quality strategy approach, both in terms of the not just in terms of how estates work, but also in how in terms of theatre work, to double check that this is all happening and to record that act as a safety, a buffer, if you like, or a last check that all the theatre systems are active before we operate on any patient, and that's taken into account in the SOP. And obviously, we had to provide those reassurances both to the chief executive and the medical director at GGC before we were able to do any of this. And we have worked closely with infection control, who were asking for the use of the authorised engineer extensively throughout our sites, despite the fact that the places we're doing most of the switch off are actually very modern, well, certainly less than 20 years old, and are also subject to the normal day-to-day checks. Hopefully that answers some of those questions, but thank you.
Mike?
Yeah, Ken, I see that some of the sort of questions are coming in there saying about, be careful about making assumptions about what's there and what's not there. Well, yeah, I mean, I was in States Direct for 20 years. I know the world's not a perfect place, but the reality, you can't not do something because, I mean, I'm assuming that none of these systems have failed their validation and verification, because that's something, to a step, that's a step you got to ask whether it's really safe, safe to be using it. But there are often with older systems, things that you need to do, things that you need to, keep it running for a couple of years. I quite understand that, but that's still, they're not going to impact upon what you're trying to do here if you're looking to, to save energy and save carbon. And it's how you work with that. Hence why there is a list of start with doing nothing and working your way down as to what you can do, because it all helps. But the idea is sort of wetting out in ducts and wetting out in systems. I mean, I've been around ventilation systems a long time. I don't see that sort of turn, if it's properly designed and maintained, I don't see that you're gonna, that you can get problems with it. And you start thinking about condensation, you need to start looking at your psychometric charts and the volumes of air that you're actually talking about, because the quantities of water are minimal. And so and it's static air, it's standing there, there's no flow to it. Even 100% humidity air filling a duct, you're lucky if you get a teaspoon of water out of that. And again, it's surface conditions, what you're doing it. So there's, I mean, there is and as Malcolm has pointed out, Scotland's absolutely under the scrutiny for its quality of its ventilation and what we're doing. So things have to be sort of, but you do. I would say you need to do a sort of a full-blown risk assessment on it. I mean, if it's got its validation and verification, you're proving that system can give that, the quantity and quality that you need to give the right indoor air. So you're halfway there, and ifs and ands and maybes, you need to sort of consider them and answer them. I would say.
Thank you, Mike. Back to you, Mike, again, from a question from Pavan in Tayside. He was asking why in your option chart, why steps 2 and 3 are mentioned. Obviously,
I've just answered that one, Ken, because the world's not a perfect place, and you need options.
So the specific question was: are there some setups that cannot be turned off completely?
I wouldn't have thought so. No. If it's in accordance with the HTM, no, I wouldn't have said that.
But if you're, I think the point he was questioning really was if you put the argument forward that needs to be switched off, and the answer comes back it's too old, it's too you know, we're worried about it being switched back on, which is something that we've heard from before. As you say, the question would be then, well, you know, does it pass its yearly check? Should it be checked over by an authorising engineer? What's the process that you would ask your estates team to go through if that's the question, if that's the argument you're getting back, that they're not sure about the age of the equipment?
Well, Ken, I mean, it's that there's 1,000 different things you'd go into, and hopefully those options cover it. I mean, like if you had the reality that you only had single speed motors, you've got an old sort of you know, Colt Holland, 40-year-old Colt Holland, great big centrifugal thing, trundling slowly away doing your supply and extract, and you're worried about it starting, you're worried about the bearings, you're worried about 101 things. Well, and you've got no setback because it's a single speed motor and it's not going to take having an inverter stuck on it. You can keep the supply so that you keep the pressure there, and you would turn your extract off, so you're saving that energy from the extract, and you're not impinging on any worries about anything getting into the ducts, anything sort of, you know, not getting in there. So it's a you know, you've got more than one golf club in the bag for what you're trying to do. I think is that way of looking at it. You know, okay. The standard to aim for is to turn your you know, your services off. But again, with the age conditions, problems with duct work, you know, problems with, you know, the age of it, there's various options. I mean, you need specific questions. You know, each thing. If you've got an old system which is not compliant with the modern standard, and but you're happy with the internal air quality, you know, there's various things that you have to do to sort of maintain that and consider it, and hence the options.
Yeah. So I think it reflects a lot of the comments in the comment section in the chat there about boards having a huge variety of different age and design of systems, and really they have to go through every system to see how it works and what can be done. But the monitoring and the standards should be the same across the board. So I'll move on to something that mentioned from Lindsay Guthrie. She's looking, is there an exemplar SOP for setback? And it actually ties in with a comment, I think, from Lorna saying that the SOP is potentially going to be peer reviewed and made available to everyone. Is that correct?
Yes, it is. We are still working on that. Malcolm's been writing it as we've been learning and moving along. And obviously what's going to work for us might not work for someone else, but because of our estate and the age of some of it, then I think it'll be applicable more or less across the board. Malcolm, do you want to add anything?
Yeah, I'm happy to share that. As I say, I think we've essentially moved to a slightly stratified approach, really, for plant that's under 20 years of age and is meeting all its requirements and is checked and is fine. Then frankly, we have been utilising authorised engineers just as a sort of belt and braces kind of manoeuvre, basically, more than anything else. Whether other people like to do that, that's up to them. But the strategies we put in place are very much the lowest risk possible. We have not been taking any risks at all with the strategies. We haven't, for instance, included the lights or the anaesthetic gas scavenging in the current strategy. So those energy savings are without those in. And we have been utilising the most modern equipment in the theatres to have, you know, utilise the infrared sensors to have a double knock setting, whereby if the cleaner goes in to clean the theatre stays on for an hour afterwards, and we've still managed to achieve all those savings. But there's going to be a separate section, very much speaking to what Mike's saying about plant that's older than 20 years, of which we have a considerable amount. Pretty much as he's described, we have the 40-year-old pieces of kit that are barely functioning, and what we've been doing is doing what we can on those sites as far as the REH is concerned, and as far as the Royal's concerned, we haven't managed to get in there yet to deal with that, and we will risk assess that. We again will probably do individual risk assessments on theatres or groups of theatres using the authorised engineer there to work out what we can do, and but it will also probably be part of a capital replacement plan to replace old motors that run on bearings with magnetic bearings, to look at motor replacement, to look at replacing plant that's completely out of date and is not really functioning properly anymore, or is barely functioning. So that's when I say that this has become part of a whole quality improvement strategy, that it really isn't just switching off plant. It actually becomes part of a quality and safety strategy that has to run throughout the board, basically, and actually build into the board strategy kind of going forward. Thanks.
Yeah, I think just to come in and what Malcolm and Lorna touched on there, just because I'm on OCD, that the SOP's been constantly revised. So it started out around the trial, and it's being revised as we go, and things are added in, and as that belt and brace, as extra controls, and we're keeping track of that. And Malcolm touched on it. It's fundamentally, this is about quality management. What SOPs do we need to run our theatres in a standardised, safe manner? Who owns those documents? Where are they stored? How do we audit ourselves? And there are audits, and where there's non-compliances for those audits, where does that feature in our risk? How do we use that risk to then direct our focus on funding and prioritise that funding? It's about getting the basics right, and what we're finding is it's a mixed picture of approaches to how we manage theatres, and that's what's making this hard. Fundamentally, what in the face of this is just switch the theatres off or set them back. It makes it harder than it should be at times, and it's about getting back to basics. And through this work, we're finding other improvements and other benefits from it. So as much of it as delivery plan and green theatres and sustainability and value, it ties into multiple other aspects of quality strategy, risk within board priorities, and it should be viewed as such.
Thanks. There's a question in the chat for me. In fact, I wasn't expecting that, but the question is additional resource to support SSI surveillance included in the Green Theatres programme? So the answer is no. We don't actually have resource to give out from National Green Theatres programme. But the good news is, and this is something that's featured in an awful lot of the actions, is that the savings, the potential savings that can be made with the actions can fund the action itself and still deliver savings to the board. So as I mentioned earlier on, one of the difficulties I think is when you do make savings, it's being able to hold on to those savings, keep them, and moving them into a different financial silo. I think, for instance, the best way to tackle that, and something we've recognised in a lot of the work we've done, is if you engage all the stakeholders as early as possible in the process, you can then build in this sort of switching of funds into the action. To give you an example, if you're developing an action plan to put this in place, and your IPC people are there at the table in the first meeting, then the things that you're suggesting you have to put into theatre, such as infrared monitors or other technology, can be also, you can put that beside that, also increased SSI surveillance required as part of the startup costs of this particular action, which might make a little dent in your overall cash savings, but is likely then to have embedded itself within that. So you're not chasing your tail after you've handed over effectively the savings. Martin, you've got a comment on that.
I think you're on mute, Martin.
Sorry. One of the key drivers for us in this was S&V, sustainability and value, spend to save. What was it before? Financial improvement or small change matters. We use mandates where we're saying we could expect to save this, but we'll need X, Y, Z to facilitate that. All the interventions we've made so far has been top slice from that. It's just about having discussions with your financial planning or heads of finance to make them aware of, the kind of seed funding to get this up and running. And that's been one of our main advocates for driving this. But equally, it's a double-edged sword in terms of great, you're going to do this, when, how quickly, and then on the other hand, it's about the controls, the risk, infection control, health and safety, and doing it in a pragmatic, controlled manner, while also, I won't say keeping the bills at bay, but managing finances expectations around about the savings which you've promised. But it's one of the best vehicles to get this up and running.
Okay, thank you. Malcolm?
It's just to say that while I think SSI audits may be good, and if I had a choice of having them or not, I would definitely have them. Our infection control certainly have been less bothered about it than I would have thought, and they're far more bothered about the process being standardised, that the estates processes, that the theatre ventilation management processes are standardised in terms of the ventilation and in terms of how the theatre teams work with the theatre system management, the theatre ventilation management systems, to assure that they're working properly. So we found much less pushback than we thought we would have. Now, obviously, we have a presence at the M&M meetings, and we have obviously surveillance of what's happening in the specialties that we work with surgically. But we've found not having the SSI was kind of less of an impediment than we thought it was going to be. It's actually been easier. So I just thought it was worth mentioning that certainly our own infection and prevention control have been less bothered about that than I would have thought they would have been. Thank you.
So just about who's less bothered and who's more bothered. Lindsay, Lindsay Guthrie is on the call. I don't know if you want to ask this yourself, but she's made a comment. I think we need to be careful about making assumptions about what should be in place and functioning, performing as intended, particularly in really aging estate. And she says, I don't feel assumptions are being made. This is a risk-based approach. I don't know, Lindsay, do you want to come in on that? Because obviously you're concerned about that.
Yeah, thanks. So I think in trying to take a standardised approach, I think I'm just really thoughtful that we don't really have a standard estate and the condition of the estate. And I think there's definitely something at board level about the assurance and the evidence of assurance that we have around the current functionality of many of our ventilation systems. And I think certainly that's been a conversation we've had locally in Lothian, because some of our aging ventilation systems are really operating, I would say, at the limit of what is considered safe and appropriate in terms of design and function as part of that annual verification. And not all are designed to the SHTM 0301 standards. So, you know, in terms of the filters and things. So I just think, I think there is a level of caution, I think, just around trying to approach this in a standardised way, given the diversity of estate that we've got. And I think the first point is understanding what you have in your estate and what level of assurance you have internally. And I think Malcolm Watson made that point about understanding that systems, processes and the assurance is working as you expect. But I would genuinely, in our experience, caution against making too many assumptions about the physical estate and what we think it's doing, because that certainly hasn't been our experience in Lothian.
I mean, just to sort of come back on that, I mean, the actual indoor air quality, indoor air quality requirement hasn't changed from 2025 to either of the two versions of 0301. It's just the technology and the ways of achieving it, so that the standard you're looking for is the same. And obviously, unless there's a direct life safety implication, the HTMs aren't retrospective. So if you've got an old theatre which is a 2025 plant and it's still meeting that, it's still, in your IAQ is achieving that's your control piece. If your kit is worn out and you've got problems with it anyway, probably the last thing you want to think about is saving energy. Although you've got to get the service out of it, and that just that sits on the safety, risk and reliability assessment that you need for your board assurance framework.
I think that's the point I'm trying to make, Michael, is that some of the age of the estate and some of those systems are sitting right on the cusp of, we're keeping them going and coaxing them to keep going. And there's a piece around the capital investment. And I think it's just, so I don't think there's any barrier and there's no block to what we're trying to achieve around setback. I think we're just trying to advise that we do this cautiously and carefully in understanding the local context and what we've got in the way of the local estate, because some of the theatres are really approaching end of life very rapidly, and we don't want to tip them over the end and create an unintended risk of actually turning off a whole load of surgical services, which is a much bigger issue.
Yeah, I know, agreed. But I mean, the thing is that, you know, assumptions are a dubious way to go, particularly if you do end up in court with it, and you really need a safety, risk and reliability process where you've proved that it's, you know, you've got your risks to as low as is reasonably possible and they're tolerable, and that's all you can do, apart from, as you say, you know, cessation of the service, which nobody wants. So it is, you know, it's working towards that and being sort of clear where you are and what you're, you know, as I said, you're not going to worry about saving power if you're worried about maintaining the service. But then, you know, that's that bigger question about that you need to, you know, do something with the kit. But again, you know, there's a majority of kit that doesn't fall within that, and it's so yes, you need to be sensible, and you need to work in a planned way with a well-reasoned argument about what you're doing and why you're doing it. But I mean, it won't apply to all areas. Hence, I go back to why there's the shopping list of steps you can take. But I mean, those that can need to, you know, embrace it and get on with it.
Is there not also an argument, Mike, that for aging systems with this this idea of switching back, saving energy by switching off, but there's also an argument for modernising old kit with more efficient modern kit. By combining these two, you could actually utilise the potential savings being made to replace that old kit now before it fails. And you avoid the service interruptions that might entail.
Yeah, but it does, Ken. But the things have been, I've been a director of estates, and there's no finance people on here that'll have me hung. But you know, the finance directors like taking the savings; they don't like giving it back out to you. So that's the problem. That you know, that sort of, you know. You know, save to invest strategy tends not to, you know, when you're scrabbling to keep services going, it tends to be something that doesn't happen. But again, and going back to, you know, Lindsay's point about having some form of safety, risk and reliability assessment that you can put into your board assurance framework, that points to the fact that, you know, you could do better, but you're maintaining the service, but it's not forever. And if you don't get the investment, you know, you're not going to have the service.
Yeah.
And I think that, you know, as the various stages of the public inquiries come in, there's going to be even more and more scrutiny on that, and the you know, the suitability and sufficiency of the systems that we've got, you know, providing these environments for, you know, for surgery and clinical care.
Thank you, Martin.
Yeah, I think it's just that I mean, it's a far bigger fundamental question around letting assets run to the almost keel over. You know, it's a shift away from being reactive to proactive, knowing your assets, maintaining your assets, knowing they'll come at the end of life, investing ahead of time. Money spent today will make savings tomorrow approach. This is one of the many arguments to do it, but the fundamental argument as well, it should be around the resilience of service and patient safety. So there's probably a bigger question here around, you know, if assets are on a sugary peg, they should be getting replaced regardless. This is just one of the many positive, you know, fallouts of that investment, and that there's better controls, better resilience, carbon savings, and a financial dividend from it, because they're the more resilient and controllable asset.
Yeah, thanks. Okay, we're getting near the end. I've just got a couple of more specific questions. One for Mike. Does laminar flow for joint replacements affect switch off setback or SSI?
In what way? I mean, your laminar flow is just a recirculation system within the theatre, and I mean, and hopefully I haven't got that on all the time anyway. But certainly it doesn't. If you do get any contamination in the theatre, your laminar flow hood's going to take it out even quicker than supply and extracting. So I wouldn't have thought so.
Good. I'm going to come to another question, but I'd just like to highlight Paul McConnell's comment there. Running assets into the ground in the airline industry is known as the tombstone mentality. Malcolm.
Thank Paul for that comment. That's focus our attention. In terms of laminar flows, or as ultra clean theatres, as the states often refer to them, we've taken the approach of interlocking the laminar flow with the standard HVAC system in that theatre and not allowing the theatre to work. That there's ability for the system to work as a non-laminar flow theatre, just as a standard theatre. We've not allowed that. We've either said the theatre's either all on or all off, and that just makes it very simple. And we've taken the same approach to sometimes we have combined setup rooms for theatres or combined, dirty rooms for theatres. If any part of the theatre's on, the whole system's on, basically, and that just makes it much simpler. I mean, it's not as good for energy savings, but it's just a low-risk way of working. It's a very simple way. And for anybody who thinks that laminar flows are always switched on or off, I'd just like to disinvest them of any thoughts that anybody has any standardized protocol at all anywhere. It really depends who's on that day and what they feel about when they switch the laminar flow on or whether they switch it off at the end or not, and whether the dampers are working on the laminar flow. So I'll just leave you with that thought. I think we need to work with standard systems to reduce risks as well as provide energy savings. And laminar flows are just one example of that. That you open a whole can of worms basically when you start looking at these systems in theatres. Nobody understands and nobody works to any standards at the moment anywhere. Thank you.
I mean, picking up on Paul's comment, that he's absolutely right. But tombstone mentality leads to tombstone legislation, which is what we've seen at Grenfell, and that's unfortunately where this country heads at times. But let's hope the public inquiry doesn't do that for us. I mean, there's been a lot of mention of human factors and behaviours, and that is key to all of this, because it's got to be a holistic approach that works with everybody again. Because I mean, it's how your cleaners clean the theatres, how they work, how you can maximise that. Because if you just have a small group and they go from one to t'other and they cover it within 8 hours, that isn't the most cost-effective way to do it. And it may be that you look at changing your sort of cleaning requirement and how you do that to an enhanced team, to do multiple areas. But again, it's horses for courses. But I mean, the human bit and about how people do things and having to change practices cannot, culture trumps practice, as they say. So it is that it needs to be a holistic approach that incorporates all those and definitely focuses on the human factors. And
amazingly, Mike, you've just answered the question I had left to ask you. So thank you for that. Again, yeah. And I think that's a good way to finish. I'd like to thank our speakers, Martin, Lorna, Malcolm, Paul and Mike, for a very interesting introduction and led on to a really good discussion. I hope that everyone has an idea of how to progress the circular action.